and it will be referenced at the end of the lecture. Next slide, please. First, we're going to review some of the common organ dysfunction that you'll see in patients with COVID-19, specifically in the intensive care unit, as well as sepsis. We'll go over the organ dysfunctions specific to this infection and then attempt to formulate optimal treatment plans based on what your hospital capabilities are. Next slide, please. As you're probably aware already, the coronavirus enters the body through the ACE2 receptor. Typically in the ICU, we approach a patient based upon systems, the neurological system, the cardiac system, etc. However, a basis that begins with the immune system will allow for the integration of the other systems as we continue on. Next slide, please. The coronavirus leads to a decreased CD4 production within the body. It also leads to poor functioning CD8 and natural killer T cells. Poor viral clearance and antibody production, along with the previous two things mentioned, can stimulate further macrophage activations and uncontrolled loops of self-amplifications. In some patients, it stops here. Unfortunately, for others, it can become much more severe, and this has been termed hemophagocytic lymphohistiocytosis, or simply an acquired cytokine storm. Next slide, please. And Dr. Brennan will take over from here. It doesn't appear Dr. Brennan's been able to join us, so I'll continue on here. This image depicts a progression of the coronavirus, beginning with mild COVID-19 on the left in green, progressing all the way to severe COVID-19 on the right in red. What you'll see is that I'm sorry? What you'll see on the left is the green, that is an uninfected individual, and on the right is the severe. I'm sorry, I'm having an echo with an interpreter. Thank you. So if we look at the screen from left to right, the patient progresses with coronavirus. When the patient initially develops the coronavirus, common presenting signs are going to be fever, cough, fatigue, and generalized body aches. Inflammatory mediators throughout the body are similar to what you would expect to see with other infections. These include interleukin 6, interleukin 10, a various host of T cells and lymphocytes. When it progresses to severe coronavirus, this is when we start to see that cytokine storm that I mentioned previously. Patients will begin to develop a host of multi-organ dysfunction that we'll cover next. Next slide, please. The common clinical manifestations that we just covered are general, and in China and Italy specifically, we've seen fever, malaise, fatigue, and cough. Throughout the world, we're beginning to see clinical manifestations in other areas of the body. This has included chest pain, neurological symptoms such as altered mental status and headaches, and even gastrointestinal symptoms, including nausea, vomiting, diarrhea. More recently, we've come to recognize that patients can also lose a sense of taste and smell and develop runny nose or rhinorrhea. As we know, the virus enters the body through the ACE2 receptor. This receptor is known to be expressed within the lower respiratory tract of the body and in the enterocytes of the small intestine. This could likely explain why we see some of these symptoms in the virus. Next slide, please. While the presenting symptoms are broad and nonspecific, we do know that once the cascade of viral replication begins, it can progress from a cytokine storm to a severe multi-organ dysfunction. This shock state is where we hope to prevent patients from going and or rescue them from. So with that, we're going to go into shock. what we'd like to start off with, it looks like Dr. Brennan has been able to join us here, and I'll let her take over from this standpoint. Dr. Brennan, we're discussing the first stages of shock.
Great, thank you, Dr. Bruns. So in your initial assessment and management of patients with shock and COVID-19, dynamic measures can be very helpful. So things such as the passive leg raise can help you to predict fluid responsiveness in these patients. So simply raising the patient's legs up in the air and looking for a response in systolic blood pressure of greater than 20 millimeters of mercury or diastolic blood pressure greater than 10 millimeters of mercury can help you to decide would this patient benefit from giving them a bolus of fluids or continuing IV fluids. If you have the ability to place arterial lines and you routinely do so, you could also use pulse pressure variation, if that's in your practice, to do the same thing to help predict if these patients will be responsive to fluid. Skin temperature is also an important and useful tactic to kind of predict which patients will be responsive to fluid or not. So if a patient has warm skin and they're hypotensive as well, you should be thinking, does this patient have sepsis or distributive shock? If they have cool skin, on the other hand, you should be thinking, is there some sort of cardiogenic shock component, or is this patient just hypovolemic? Could you advance this slide? Thank you. If you have the ability to measure lactate, that could also be especially useful. Elevated lactate can be a sign of tissue hypoxia, and trending lactate or lactate clearance directed therapy can help to manage these patients and may allow you to reduce mortality and shorten their ICU stay. If you don't, if you can't measure lactate and this is not a lab that you routinely are able to get, a bicarbonate level on a metabolic panel can be used as an alternate marker, and that can be trended just like a lactate. Additionally, if you have a transthoracic echo available, this can be helpful. Even basic transthoracic views like a parasternal short and long view and an apical 4-chamber view can help you to kind of guide treatment and compare echo views at different times in the patient's resuscitation. Can you advance that slide? Thank you.
Now that we've covered what we'll start to see in the shock state, it's important to address how to treat the shock state. Initially, we want to start off with fluids. Using crystalloids as opposed to colloids is preferred, specifically using Ringer's lactate, Normisol, or Plasmolite. We'd like to recommend that you avoid any fluids containing albumin, dextrans, or simply colloids, as well as normal saline. Additionally, while treating these patients with fluid boluses, we want to do this through a guided approach, whether that's through a physical exam or some other method that you have available at your institution. Starting off with a conservative approach is best. This is due to the fact that too much fluid could worsen the patient's already hypoxic state, and it could potentially lead to decreased perfusion pressure to vital organs throughout the body. Now, of course, if we do notice a worsened hypoxia for this patient, we want to stop any additional fluid. If we can advance the slide, please. If additional fluids do not seem to be resulting in an improvement for the patient, then we start talking about vasopressor therapy. Vasopressor therapy for the COVID-19 patient is no different than vasopressor therapy for any other patient that you may be treating with shock. So with that, we would start with norepinephrine as the preferred first-line vasoactive agent. If it's not available in your hospital, we would suggest using either vasopressin or epinephrine as your first-line agent. However, if norepinephrine is available and you're having to escalate your doses of norepinephrine rather quickly to achieve a mean arterial pressure of greater than 60, then we'd recommend adding in vasopressin in addition to your norepinephrine, so 2 agents at once. If vasopressin isn't available, epinephrine could be used as a replacement. We'd also recommend avoiding dopamine if possible, as this has been known to lead to cardiac dysrhythmias. Next slide, please.
A little bit more on vasopressor infusions. It's preferable to run any vasoactive agent through a central line. However, central lines may be logistically difficult for some of you to obtain or just not available. In that case, a large IV, so an 18 gauge IV or larger, somewhere preferably in the elbow or higher, so in a larger vein, can be used easily. And ideally, these vasoactive agents will be run through a separate IV pump. Again, understanding that that may not be available or be logistically difficult to obtain. You can add either norepinephrine or epinephrine to a bag of fluid of any size. 1 liter is probably the most reasonable because that's the most easily available. And many people have these flow regulators shown it probably looks like this small white apparatus on the left of the screen, that picture there. You can use a flow regulator to help to titrate your vasopressor to effect. If you don't have one, certainly a roller clamp can be used as well. This is a time when the drop counting method of knowing exactly how much pressure you're delivering is probably the easiest way to know about what rate of pressure you're delivering. If you have it, it's ideal to use a different fluid line, so a second IV with a second set of tubing for volume resuscitation and other medications. Go ahead and advance that slide. Steroids can be helpful in the COVID-19 patient. So for patients that present with refractory shock, steroids are likely useful and should be considered. For patients that have ARDS and COVID-19, there is some debate about whether steroids are helpful, but they may be useful, especially in early ARDS. 200 milligrams of hydrocortisone daily is a reasonable amount. You can either give this as a continuous infusion, or it's logistically probably easier to deliver 50 milligrams every 6 hours. Go ahead and advance that slide.
We recognize that you've had other lectures prior to this, specifically addressing ventilator strategies and pulmonary physiology with the coronavirus. However, we want to reach back out to this section of the body, especially since we're covering the critical care through a systems base. So we'll address the pulmonary system here. Initially, when the coronavirus was coming around and reaching a pandemic status, healthcare experts thought that it was best to intubate and mechanically ventilate early. As we've gained more experience and more literature has been published on the subject, we now recognize that avoiding mechanical ventilation, if possible, is best for these patients. This eliminates ventilator-induced lung injury. Some ways to attempt to avoid mechanical ventilation are to use a high-flow nasal cannula if available at your institution. If this isn't available, a form of non-invasive positive pressure ventilation may be useful, such as BiPAP or CPAP. Now, of course, the concern with either of these options is that we would want patients who have tested positive with coronavirus to be isolated from other patients, as these result in high flows of aerosolized coronavirus particles that could infect other individuals in the area. Other things to note: if you have reached a point where a patient becomes so hypoxic that mechanical ventilation is necessary, once the patient has been intubated, what we tend to do is we try to complete all procedures at that time. These patients are prone to spreading their disease through aerosolizing procedures, so we would recommend avoiding bronchoscopy, but it may be wise to start with a central line at the same time that you're placing your endotracheal tube. Again, we'd like to highlight that a conservative fluid management approach is best. And a couple other things to mention here that may have been mentioned previously, but just highlight those once more. Proning helps these patients significantly, whether they are ventilated or not. And these patients can also develop, on top of their viral infection, a superimposed bacterial infection. So empiric antibiotics specific to your hospital's availability may be appropriate as well. If you're still having difficulty ventilating the patient who's been intubated, paralytics can be used. Next slide, please. This is a little handout from the Society of Critical Care Medicine that conveniently describes kind of what we just went through. On the left, you see a patient that has mild ARDS. The standard ARDSNet approach of lung protective ventilation is key for these patients, just as it is in any other critically ill patient. You also want to treat potential bacterial infections. There's no need to target a blood oxygen level of 100%, we can target all the way down to 92%. As the virus progresses to moderate to severe ARDS, increasing the PEEP may be wise, prone ventilation, as I previously mentioned, and the potential for a paralytic to help with ventilation strategies. There are some places here in the United States and a few other places throughout the world that are using extracorporeal membrane oxygenation, or ECMO. This is simply used as a rescue therapy, but it has not been proven to be any more effective than prone ventilation is, and therefore we highly recommend prone ventilation if possible. Next slide, please.
Moving on to the need for inotropes in these patients and in general in patients in septic shock. For some patients, cardiogenic shock exists concurrently with septic shock, either as sepsis-associated cardiomyopathy or specific to coronavirus patients. They could have an acute COVID-19 cardiovascular syndrome like a myocarditis, which we'll discuss here in a minute. These patients have evidence of poor perfusion, so their lactate is rising, their skin is very cool, and they have evidence of organ dysfunction, rising creatinine, elevated liver enzymes, despite appropriate fluid administration and norepinephrine. Again, transthoracic echo can be very helpful in these patients looking for a decreased ejection fraction. If you have a patient like this that has a decreased ejection fraction in COVID-19, dobutamine is a good first choice for inotropy. This would be preferable to just increasing your norepinephrine doses to get a mean arterial pressure of 60 to 65. Go ahead and advance that slide.
As Dr. Brennan alluded to, patients who develop cardiac complications have now been termed to have what is called acute COVID-19 cardiovascular syndrome. This can manifest itself in two different ways. One, through an inflammatory response. If you're looking at the figure, that's the bottom right portion that we'll see where the virus enters through an inhaled process into the lungs and results in a massive cytokine response throughout the body that we've spoken about. This can lead to a hypoxia-induced myocardial injury or simply a cardiomyopathy. The second mechanism is through the virus itself, and this would be on the top left arrow, as it results in an ACE2-mediated direct damage. Essentially, the virus is replicating within the cardiac myocytes themselves, leading to this myocarditis. Specifically with the myocarditis, patients who have myocarditis are developing prolonged QT syndromes. These can lead to cardiac dysrhythmias, specifically ventricular dysrhythmias. These are the ones that are most likely to lead to a cardiac arrest. On the cardiomyopathy side, again, patients with a high amount of inflammation tend to have more atrial dysrhythmias. Bringing both of these together, we can see that patients who have existing coronary artery disease are likely to have a higher mortality rate, simply due to a decreased perfusion with an increased demand, leading to more myocardial ischemia and necrosis. Lastly, I'd just like to mention that as the virus replicates and the cytokine storm takes effect within the body, a downregulation of ACE2 receptors throughout the body results actually in an increase of angiotensin II, inflammation, and reactive oxygen species. So a snowball effect of this cytokine storm. Next slide, please.
To continue to discuss some of the complications in these patients, we'll briefly touch on infection. So fever occurs in almost all of COVID-19 patients at some point in their disease, although maybe the presenting symptom in about 40% of patients. If your patient develops a fever during their stay, paracetamol or acetaminophen should be used to treat their fever. There's insufficient evidence now to suggest avoiding NSAIDs. So it, as of now, is fine to use NSAIDs to treat these patients as well. For mechanically ventilated patients with concurrent respiratory failure, antibiotics should be given. There's no evidence to suggest a superior antibiotic regimen, and this should really be guided by your institution. The antibiotics you use should definitely cover for hospital-acquired pneumonia. Go ahead and advance the slide.
As we move from infection to the neurological system, we do so with the understanding that the coronavirus can lead to a host of different clinical manifestations, as we described previously. So again, focusing on the neurological system. In a retrospective study out of patients in Wuhan, China, 214 patients were examined. Of these 214, 126 were deemed to have a non-severe infection, with the remaining having a severe infection. Of the 214 patients that were examined, 78 patients, or 36%, had neurologic manifestations. As you can see below, these numbers highlight those neurological manifestations in severe versus non-severe cohorts. They were deemed to have acute cerebral vascular diseases, impaired consciousness, and skeletal muscle injury. You can advance that slide, please. Other neurologic complications include all of these shown on the left. Specifically, I'd like to point out seizures, the potential for meningitis, and of course, critical illness neuropathy. The most likely of any of these that you'll see in your COVID-19 patient is delirium. It's one of the most common complications of the neurological system that we see in critically ill patients, especially those who've been present in the ICU for a prolonged period of time. And we'll talk a little bit more about that next. Next slide, please.
Just to briefly discuss delirium prevention and management, there is a bundle called the ABCDEF bundle that you may or may not be familiar with that can help both prevent and manage delirium in the ICU patient. This comes from the Society for Critical Care Medicine, and there's many resources on that website concerning this bundle. Things that have been shown to be helpful include both spontaneous awakening trials and spontaneous breathing trials. That's the B of the bundle. So allowing your patient to be off sedation at some point during the day, and then allowing the patient to breathe, hopefully on a spontaneous mode of ventilation, to assess for readiness for extubation at least daily, if not more than once a day. I'd like to point out specifically that choice and amount of sedation is very important in these patients, especially patients that are intubated for some time, sometimes weeks. Decreasing sedation as early as possible is one helpful way to mitigate delirium. Go ahead and advance that slide. We have seen that these patients have GI and hepatic abnormalities. The incidence of elevated liver biochemistries in these patients is anywhere from 14 to 53%, but they're usually mild, so about 2 times the upper limit of normal, or even a little bit less than that. They're more common in patients with severe disease, and this is usually transient, so no specific treatment for these elevations in liver studies. This could be from either direct virus-induced damage or as a result of immune damage. If you routinely measure serum albumin, this could be a marker of disease severity, specifically for COVID-19 patients. Liver biopsies in these patients have shown very non-specific findings, and it's probably not necessary to pursue a liver biopsy in these patients. If you have a patient with pre-existing liver disease, they're at higher risk of having severe COVID-19 infection. Go ahead and advance that slide.
So moving from the GI and hepatic system, now we're going to talk about the renal system. Before we describe this image in front of you, if you were to test the urine of a patient with coronavirus, some of the studies now are reporting that the following is what you would find on admission. 34% of patients would have albumin present in the urine, 63% would have protein present, and 26% would have hematuria. Moving specifically into the image in front of you, there's 5 different mechanisms listed here for how a patient with coronavirus may develop acute kidney injury. The first one, hypovolemia, is likely due to all of these patients having severe hypoxia. Oftentimes in patients with hypoxia, we attempt to aggressively diurese them. This aggressive diuresis could lead to an induced hypovolemia, leading to the kidney injury. The ATN, or acute tubular necrosis, can be due to a cytokine storm within the body, as we've previously discussed. There are some reports that are showing specifically involvement within the glomerulus of the nephron. And we know that the virus is leading to a hematological response throughout the body that could also be at play here. If a patient has concurrent cardiogenic shock or possibly has RV failure secondary to aggressive ventilation strategies with high PEEP levels, They can have low perfusion of the kidney as a result of venous congestion. So low perfusion pressures are a problem. The last mechanism that could be contributing to acute kidney injury in the virus is direct viral infection of the epithelium. So the virus replicating within the renal cells. Next slide, please. If your patient has acute kidney injury, it has been shown to be an independent predictor of mortality with coronavirus. If your institution has the ability to perform dialysis, there are some thoughts that this could help to remove inflammatory cytokines. You're likely to see this as a need during the second week of infection. It's been recognized that continuous dialysis is likely better than intermittent dialysis. If you admit a patient with coronavirus with pre-existing kidney disease, you'll likely want to consider a referral to another hospital that has the capability for dialysis. Next slide, please. This is a compilation of studies showing that throughout the world in patients with the coronavirus, a total of 1,200 patients. We know now that there's millions of cases, but specifically in these 1,200 patients studied in these different publications, 11% of them had acute kidney injury. 5% required renal replacement therapy. So this is something you're likely to see. Next slide, please.
Just to briefly discuss the hematologic considerations in these patients, I'd like to focus on the center part of this slide. So hemostatic abnormalities that we've seen in COVID-19 patients include pulmonary microthrombi. We see many kind of microvascular injuries, and then also intravascular coagulopathy. Lab abnormalities, these patients oftentimes have an elevated D-dimer degradation. The fibrin degradation products are oftentimes elevated, and they often have an elevated PT. Their platelets as well are oftentimes low. Go ahead and advance that slide. Elevated D-dimer is a possible predictor of mortality, and if you have the ability to measure a D-dimer, it would be reasonable to do so in these patients. Some preliminary analyses are showing that non-survivors had significantly higher D-dimer levels than survivors for COVID-19. And other systematic reviews have shown that this actually was associated with much more poor prognosis. Go ahead and advance that slide. Low molecular weight heparin, so commonly enoxaparin, protects against VTE in sepsis like coagulopathy. For bleeding patients, it's reasonable to try to keep their platelets, fibrinogen, and PT within these kind of boundaries or parameters. Go ahead and advance that slide. This is an example from our colleagues at Emory University of what they're doing for patients with elevated D-dimer levels or known or suspected VTE. I think the main takeaway from this is that almost all of their patients are getting some sort of enoxaparin at higher doses than just for chemoprophylaxis. And I also think that if you have either a known or suspected VTE, so even if you highly suspect that your patient has some sort of microthrombi formation or an actual thromboembolism, early anticoagulation would be reasonable to pursue in these patients. Go ahead and advance that slide.
At this point, we've covered all of the different systems that may be affected by the coronavirus. And we've done so using publications throughout the world where people have noticed different things with the coronavirus. Next, we're going to specifically talk about what we've seen here at Vanderbilt and what we think may help you in your care. First of all, the Surviving Sepsis Guidelines recommend supportive care. Definitely want to stick with that. ICU admission guidelines, as unfortunately we're probably all too familiar with, may require tough decisions. The Society of Critical Care Medicine lists these patients into 3 groups: patients that would benefit from the ICU, those that are simply too sick, and discussions of further care may be warranted, goals of care discussions, or simply those patients who are too well and don't require the ICU. Other things that we've developed here at Vanderbilt include guidelines of personal protective equipment for staff and families. We have guidelines available for you to view if you would like to on exposure, aerosolizing procedures, and environmental cleaning, as well as several others that are available. If your patient with coronavirus goes into a cardiac arrest, CPR is a common question that we've been getting. What to do? This patient should be isolated. So what we have devised here at Vanderbilt is that we have a specific team that responds to the coronavirus patient that requires CPR. Only a few people are allowed inside the room. This includes the team leader for the CPR, someone who's responsible for the airway of the patient, a respiratory therapist, as well as 2 individuals to perform compressions and administer medications. Outside the room, we have a safety officer making sure that the personal protective equipment is properly put on and properly removed before exiting the room. Also outside the room, we have an individual relaying medications, manning the code cart, and recording the event. Specifically during CPR, this differs from usual CPR. We do not want to use bag mask ventilation as it could spread the virus. Simply place a surgical mask over the patient's mouth during compressions. When the person responsible for the airway is ready to intubate, we actually hold chest compressions again to try to eliminate aerosolizing the virus. Sadly, if a patient has reached a point of cardiac arrest, it's likely futile to do CPR. However, these are our recommendations for it. Specifically next, we want you to be aware that there is a possible need for a higher amount of PEEP in these patients. We discussed earlier that prone positioning is very helpful. Sedation, as Dr. Brennan mentioned, is best kept to a minimum, but if propofol is used, just recognize that there is the possibility to develop propofol infusion syndrome, and these patients are likely going to present with a severe hypoxia out of proportion to their clinical picture. Next slide, please. At this point, we'd like to open it up to any questions you may have. The following slides will show those references that we said are responsible for each of the slides in this presentation.
Thank you so much, Dr. Brunn and Dr. Brennan. That was fantastic. We also have 2 other doctors, Dr. Banerjee and Dr. Rengel, and all 4 of them will be answering the questions that we have. We have some that have come in on the chat, and if you do have any questions and you'd like to put them into the chat, we'll ask them. We also have several that came in ahead of time. But I think that we'll start with one that came in on the chat, and doctors, any one of you can feel free to answer this. If the patient is recovered from COVID-19 but still has a congenital disease that we are discussing today, how is the procedure for maintaining health at home? What is the percentage of quality of life of the patients when at home? And should they continue to consume drugs in accordance with what they were given when they were still a COVID-19 patient?
I can field that one, Dr. Bruns here. It sounds like a patient that, if I'm understanding the question correctly, has a pre-existing disease and is being treated for coronavirus at home. This patient is already taking some medications. Not knowing specifically what that pre-existing disease is, we would not recommend stopping any of those medications, certainly continuing those. As far as the quality of life, this is going to be highly dependent upon the severity of the disease. I don't know if any of the other presenters want to comment in on that.
Okay, that's great, thank you. Next question we have, how about a new anticoagulant, and then in parentheses it says rivaroxaban indication?
So in the acute setting, when we are looking at managing complications from thromboembolism in the hospital, we prefer to use low molecular weight heparin or unfractionated heparin if that's what you have available, because it's of its shorter acting duration and because the patient's status could change, and some of these patients also and progress to DIC or have bleeding complications. And so there may be a role for rivaroxaban or a longer-term anticoagulant if the patient is known to develop a thromboembolic complication while in the hospital. But I would not, I have not seen it endorsed and would not start a patient acutely in the hospital setting on that medication.
Thank you, thank you. And this is a bit of a follow-up that came in earlier. Because of the associations of COVID-19 with thrombotic and thromboembolic disease, should we be testing all patients who present with stroke, heart attack, and pulmonary embolisms for COVID?
I think that typically what we are seeing is that the thromboembolic complications develop with more advanced disease states. And so I'll let some of the other presenters weigh in, but the likelihood of developing an isolated stroke or thromboembolic event without any other symptoms of COVID, fever, hypoxia, change in sense of smell, GI symptoms, anything like that is very low in my mind. I can't cite specific data on that, but we, again, typically see this in later stages of more advanced COVID disease.
I would agree with Dr. Rengel. There currently is no data to say that unless you have fever plus 2 other symptoms, or if you're not symptomatic, that you need to test someone for COVID-19. And a follow-up on the anticoagulation question, there are a couple of trials right now with using these drugs in patients who have documented VTE after COVID-19, but the data is not out on those trials yet.
Excellent. Any other doctors have anything you'd like to say? We'll move on to another question. This is from Henry. Could point of care ultrasound, where available, be preferred to a 2 deco to minimize healthcare worker exposure?
I can take that one. I think, yes, if you have, am I muted? No. If you have the ability to use point of care ultrasound, you could use it at several points in the patient's course to help to kind of guide your therapy. Certainly cleaning your echo is going to be an issue, so you want to make sure that you're really not bringing anything extra in with the echo. You're not bringing extra gel or anything really into that patient's room that you're going to carry into another room. Many health systems are struggling with getting official echoes done on COVID-19 positive patients just because of risk of healthcare worker exposure. So if you can bring something portable, even a handheld echo into the room, many places are actually doing that.
I'd like to chime in on this as well. The question specifically asks about point of care versus 2-dimensional echo. Point of care is certainly worthwhile to use. As Dr. Brennan mentioned, if your institution has it, we'd recommend keeping the ultrasound that you're using for the coronavirus patients separate from an ultrasound if you have more than one, separate from patients that do not have coronavirus. When using this in the room, it's important to try and protect the machine itself as much as possible. So remove anything, any ancillary shelves, anything that doesn't need to be essential, any other probes before going in the room. And then using your institution's preferred cleaning method, clean the device itself, the ultrasound machine, before leaving the room, top to bottom, front to back, everything needs to be cleaned before leaving. Now, specifically point of care ultrasound, the lung ultrasound exams are showing a milder form of coronavirus, several B lines that are being seen. As the disease progresses, this forms into a coalition of B lines that is called a waterfall sign. So we're seeing lots of lung consolidation if you're looking specifically at a pulmonary ultrasound. On the 2-dimensional echo, as Dr. Brennan mentioned earlier in the presentation, it's possible that with the cardiomyopathy of the coronavirus, you may see a depressed ejection fraction. And on a surface echo, this is gonna best be seen in your parasternal short axis view.
Thank you. And a follow-up to the question about rivaroxaban. If a patient is on rivaroxaban, should we switch to LMH or stop while he is on the progress of COVID?
So again, it depends on how serious the the patient is and what your threshold for him bleeding is. Like Dr. Rengel pointed out, sometimes we use these other agents because one, they're easier to reverse, and two, it's much shorter acting. So it's a judgment call, honestly. You've got to kind of say, is my patient going to go into DIC and am I going to bleed, versus am I more worried about the microthromboemboli, and do I have signs and symptoms which kind of tell me I'm progressing towards, having a PE or something like that. So it's a judgment call on which way you want to go.
Thank you. Another question, other than being a predictor of mortality, would D-dimer value help us change patient management in these patients?
I can take that. So the American Association of Nephrology here has kind of used that, especially in patients who are on hemodialysis, especially renal replacement therapy. And it's part of their guideline, which is what we showed the Emory VTE prophylaxis. So they're using D-dimers as a predictor for how severe the disease is and what dose of low molecular weight heparin am I going to use. If you don't have a D-dimer, it's not that you absolutely have to use it. The reason we showed that protocol is to kind of say, if you're suspecting that you may have an embolus, go ahead and treat that patient. Otherwise, at least make sure they're on some kind of prophylaxis.
Thank you, Dr. Banerjee. Any other doctors want to add on to that?
Also, just adding in, I think some of the embolic events that we commonly think about are, deep vein thrombi especially in the extremities, where we see this swelling, tenderness of the extremity or a PE. But a lot of patients in COVID are developing these microemboli that are in the digits, and so you're seeing these blackening or cold toes and fingers. And so that's another sort of clinical sign that you can use as a low threshold that the patient is developing these microthrombi and likely needs a higher dose of an anticoagulation.
Thank you, Dr. Rengel. Another question came in. Can a chest CT scanner take a role as screening before waiting for RT-PCR results?
I think if you're concerned that your patient has coronavirus, sending them to a chest CT scanner is going to expose that many more staff members, that many more patients to the coronavirus. Now, if your results for your RT-PCR are taking days to get back, this could be helpful, but you're not going to see anything on the chest CT scan that is going to 100% diagnose coronavirus. The RT-PCR is at this point considered, quote, the gold standard.
In follow-up to that, I know that had been a major methodology of screening earlier on in China, and there's been data released on that. Specifically speaking from our practice at Vanderbilt, we don't screen patients using CT scans. Chest x-rays will also show ARDS. And if you, like Dr. Bruns said, if you have a high suspicion, the RT-PCR test is the best way to go, and then to treat the patient as someone who likely has COVID. But we have not been routinely sending patients to the CT scanner to avoid further exposure in the hospital.
The other thing to keep in mind is that if you look at the publications from the radiologists, it has shown that even asymptomatic patients have VQ mismatch, and they will show perfusion abnormalities on their scans. So again, you know, it really is not going to help your management per se in any way. So we haven't been sending our patients to the scanner.
Excellent, thank you guys. We have several questions that are around fluid management and the septic patient, and so I think I want to move there for just a few minutes. The first question is, what considerations should we keep in mind if we only have normal saline available for fluid resuscitation?
Since I was speaking about the fluids during the presentation, I can field that question. Normal saline is certainly going to be preferred still over some of the other colloids previously mentioned, like a dextran or something of that nature. However, with normal saline specifically, when you start to reach high volumes of it, you're going to be looking for a metabolic acidosis to develop in the patient. Now, a lot of these patients are most likely already going to have a metabolic acidosis from the severity of their disease, and adding on to that with large boluses of normal saline could only worsen that. And so that's what I would caution you in that scenario.
I think the big thing to keep in mind is give fluids if your patient needs it. So if they're not perfused and they're not euvolemic, then yes, use your fluids. But if they don't need it, then don't give it.
Oh, great, thank you. And as a follow-up, how do you avoid causing an acute kidney injury in a septic ARDS patient if you need to limit the fluids and give vasopressors?
This is something we deal with every single patient in the ICU, and I don't think any of us are going to have a great answer for that. That's a really fine line to walk, and it's certainly something that a patient who's septic and has ARDS and multi-organ dysfunction is most likely going to develop an acute kidney injury. I can't say, other than general supportive care, that there's been anything that's going to show a way to prevent the kidney injury from occurring.
Like the presentation said, try and keep your perfusion as much as possible with the mean arterial pressure greater than 60 to 65. And that's the best you can do. If you have kidney injury, which, you know, a lot of our patients with sepsis have, and it's similar for this population, supporting them, keeping their perfusion as much as possible so that you can lessen the amount of injury would be the goal for these patients.
Excellent, thank you. One last question on the fluid is, how often should we be monitoring fluid status in COVID patients?
At this point, I don't think we have any intervals to recommend, but certainly multiple times throughout the day would be wise, whether that's every 2 hours, every 4 hours, every 6 hours, depending on the severity of your patient. And certainly anytime you see an exam change or change in their vitals, then you'd want to go back and reevaluate that fluid status. And this can be done through different ways, as we presented earlier, whether that's the passive leg raise, if you have an arterial transducing capability at your hospital, or a host of other ways, but those are the two we focused on earlier.
Just to build off of what Dr. Bruns said, I think it is important, though, to consider minimizing unnecessary trips either into patients' rooms or to that specific patient. So like Dr. Bruns mentioned, when the patient's kind of clinical scenario merits a reassessment of their volume status, opposed to just by rote every hour or something like that.
Thank you. A question, it's kind of a two-part question. How soon after admission are you seeing patients present with shock? And what are the most important labs for assessing end organ damage in the setting of shock?
I think it's variable. So some patients are presenting to the emergency room in shock from sepsis or hypovolemia or some other distributive shock. And some patients are staying here for several days or a week and then developing a shock-like state. I think if you can measure a lactate, that's very helpful just to see if this patient has any tissue hypoxia. In addition, so a baseline creatinine and knowing what the patient's baseline is ideal, and just other measures. So a baseline set of liver numbers, if you can, is potentially helpful. Again, I don't think it's necessary to get these labs on an hourly or every couple hour basis, but helpful to kind of use them as trends.
Oliguria or urine output is a very useful marker. So if you have a patient who comes in who was making good urine and now isn't making urine, that's one thing you definitely want to pursue and figure out why that has happened. And probably oliguria, cold, clammy skins, or any change in vital signs where you've given a fluid bolus and your blood pressure hasn't gone up. Those are things which kind of would point you towards shock.
Thank you, doctors. I just want to get to another question or two, and then I do want to give each of you time to say any last words. I know we're coming up at the top of the hour, but if you have, last things that you would like to say in this session. But it looks like we have a question regarding therapy from hormones like estrogen and progesterone. Can they prevent or mitigate severe conditions? Is this new evidence, or have you heard about this?
There is no published data as of yet, so we as a group, I don't think would recommend it.
Great, and there's one more, and the person who asked it, if you might need to clarify a little bit. This is the last question that we had on the chat. It says if a patient is on has chronic use as a severe VHD with AF, could you speak to that?
I'm guessing, and feel free to jump in and correct me if this is not correct, but if this is in follow-up to rivaroxaban use or chronic anticoagulation for conditions like valvular heart disease and atrial fibrillation, it is our common practice, even outside of COVID, when patients present to the ICU and have a constantly changing status, to take them off of their long-acting anticoagulants and use something shorter acting should their clinical course change and they develop a coagulopathy and start bleeding. And so I think that as long as you have a therapeutic dose of the short-acting anticoagulant on board so the patient is still anticoagulated, if you're concerned about them developing acute bleeding, that's reasonable. And like Dr. Banerjee said earlier, if the patient has not developed severe disease yet and you're not as concerned, you certainly could continue their home medications until you reach a point where you're concerned about the patient's stability. But absolutely recognizing that patient needs continued anticoagulation is appropriate.
Thank you. Anyone else? Thank you, Dr. Rengel. Any other doctors want to comment on that? I think we'll take one last question that I saw up here in the chat about CPR. Do you have any data on survival after CPR? How many survive?
I think Van asked that. We haven't seen anything. There's really no published data yet about survival after CPR. there's a lot on the ethics piece of it, but nothing really on survival CPR.
Okay. Thank you. And this has been a wonderful session, and I'm aware that we're at the top of the hour, but did want to give each of the doctors just a moment for any last words that you'd like to say, or thoughts that you have. And maybe Dr. Banerjee, since you're on the screen right now, we'll just start with you and then we can just move down.
Thank you for asking us to speak. And, you know, I think the data is so rapidly changing. It's even the SCCM surviving sepsis guidelines for COVID-19 would be a good resource. It's free and it's available on online if anyone, you know, wants to pull that up. And just keep in mind that proning and not intubating have kind of been proven to be beneficial to date, and stay safe out there.
Thank you. Dr. Rengel?
Like Dr. Banerjee said, thank you for the opportunity to speak with you this evening. I guess the final comment that I would have is as the data continues to accumulate, and of course it is changing, but we are also seeing that getting back to the very basics of critical care practice, the things that are tried and true that you do for all of your patients with shock and ARDS, are oftentimes the appropriate course of treatment in these patients. And so kind of, if you aren't really sure where to go in a course, going back to your basics and what you know is often an appropriate decision with these patients. And like Dr. Banerjee said, stay safe, and we wish you all the best.
Thank you. Dr. Brennan?
I think to reiterate, I know the just amount of data that's coming out can be very overwhelming. So to kind of reiterate what Dr. Rengel said, many times you're going to be unsure of what to do based on anecdotes or case reports or things you've recently heard. And usually the best thing to do is the basics of critical care medicine. And while we wait for these studies to come out about potential treatment and specific little tweaks we can make for patients with COVID-19, I think the mainstay will be basic critical care.
Thank you. And Dr. Bruns?
Yeah, I'd like to echo what the rest of my colleagues said. Thank you for your attention this morning. I'd also like to say that you're not alone in treating these coronavirus patients. This is going on all over the world. As you know, there are experts throughout the world working on it. If you just follow up with some of our critical care experts, I'll certainly keep you informed as to what the most up-to-date literature is. And finally, a thank you to Project ECHO, Assist International, and Vanderbilt. And please stay tuned for more lectures on this subject.
Yes, thank you so much. And really a big shout out to all of you doctors. I know that you're very busy, Dr. Brunn, Dr. Brennan, Dr. Banerjee, Dr. Rengel, and also, so we thank you for the wonderful presentation. And for all of our colleagues and doctors and healthcare workers that joined us for this call, we also just so much appreciate that you took the time. We're trying to give you relevant information, and we're all in this together. And so I do really just appreciate everyone's involvement and participation and the great questions. I'd like to thank Vanderbilt University and Vanderbilt Institute for Global Health and all of the people that we work so closely with there. GE Foundation for sponsoring this, and all of you healthcare workers who are out there on the front lines serving the world really right now. We're just so very grateful to you all. And with that, I think I'm going to pass it back to my colleague Chase. We may have a quick poll at the end that we'd like to do.
Yes, thank you. Before all of you leave, if you wouldn't mind, I'm going to be sharing a poll with you right now. If you wouldn't mind just taking a few minutes to fill out those questions for us. And then I'm also going to pass it over to Claire from Vanderbilt University to discuss the WhatsApp chat group that we've created.
Yes, thank you, Chase. Thank you all for submitting your questions. And I know we may have more questions that we haven't been able to answer. So we've started a group on the app WhatsApp. I know many of you already use WhatsApp. So this is a great way to stay engaged, stay informed. You can join our group by scanning the QR code on your screen. We'll also send out a link to your email, and you can join the group. Keep asking us questions. We have several Vanderbilt faculty members who are part of the group who will be answering your questions. Thank you.
Thank you, everybody. You should now be able to see the poll. So if you could just answer some of these questions for us, help us to understand where you guys are at, what departments you're working in, things like that, to help us bring the most relevant content that we can to you. That would be greatly appreciated, and we look forward to seeing you all on the next session. We're going to close the poll in just another minute, so if you are still working on that, please do. Thank you again to everybody for joining, as well as our doctors who presented for us. Doctors, we will see you guys again in the morning. And for all of our participants in Southeast Asia, we'll see you on Friday. Thanks, everybody. Have a good rest of your day.
Good night.
Thank you.